virtual series on women's health. Um, Yesterday was day one, and we had an incredible evening with Professor Moshe Hart and Dr. Hema Divakar and Anil Kapoor, and a brilliant team that coordinated the whole program. It went beautifully, seamlessly, and a lot of important points were discussed. And if yesterday is any indication, today is going to be equally exciting and engaging. And I welcome you all to this evening. We have none other than Professor Mark Molitch, Professor Emeritus from Northwestern University. Today's topic is prolactin and reproductive endocrinology. And I cannot think of anyone in the whole world who can probably make prolactin and pituitary sound as simple and easy as Professor Molitch can. And we also have Dr. Uma Ram, leading OBGYN from Chennai and nationally known obstetrician gynecologist, and myself, endocrinologist, and a great team helping with this program today. Just want to mention something about Divas. We are a non-profit that was started 7 years ago with the vision to see a world where girls and women live long, healthy, happy lives free of diabetes. We have just now expanded the scope of our work to actually include all non-communicable diseases, because we just found that diabetes coexists with all these NCDs, and each one, there's a bidirectional relationship between NCDs and diabetes as well. And also many of the drivers of diabetes are drivers of the other NCDs as well. So Divas has a new logo, a new tagline, and an expanded scope of work. Very excited to start the new work for Divas starting now. So today's program is on prolactin and reproductive endocrinology. Next slide, please. So as I said, it is the two really important topics, and the keynote speaker is none other than Professor Mark Molitch. Next slide, please. I think this is a very, very brief biography of Dr. Molitch. He's done such seminal work in this area. Professor Emeritus in the Division of Endocrinology, Metabolism, Molecular Medicine at Northwestern University, the Feinberg School of Medicine. Research has focused on the pathogenesis and treatment of pituitary tumors and the effects of such tumors on pregnancy, which is very relevant to today's discussion. Participated in the development of most of the medical treatments of prolactinomas and acromegaly. Member of the committees that wrote the guidelines for the evaluation and treatment of adult growth hormone deficiency, pituitary incidentalomas, and acromegaly of the Endocrine Society and prolactinomas of the Pituitary Society. Dr. Molitch has authored more than 500 original papers, review articles, book chapters, case reports, and other publications. Endocrine Society Council member, 2008 to 2010, President of the Pituitary Society, 2012 to 2013, and 2013 recipient of the Distinguished Educator Award of the Endocrine Society. But more than all of that, everyone who knows Mark knows what an incredibly great human being, a teacher, and a friend of India. So thank you so much, Mark, for doing this for us. Next slide. So these are the three people who will be the hot seat today answering questions. Professor Molitch, of course, Dr. Uma Ram, a dear friend, and the director of the Sitapati and E.V. Kalyani Medical Center, and very well-known obstetrician gynecologist with special interest in gestational diabetes. And myself, endocrinologist, and now I'm at the Voluntary Health Services Chennai. I had the diabetes and endocrinology department there. Next slide, please. So this is about Uma, an FRCOG, FICOG. Next slide. That's me. Next slide. So these are the three brilliant moderators. Dr. Belinda from Bangalore, Dr. Jayashree Gopal from Chennai, and Dr. Chitra Selvan also from Bangalore. Next slide. So Dr. Jayashree Gopal is the director of the Institute for Diabetes, Endocrine, Metabolic, and Lifestyle Health at SIMS, Chennai, senior consultant endocrinologist, diabetologist, a diplomate of the American Board of Internal Medicine, Endocrinology and Diabetes, associate dean for teaching and research at the MV Diabetes Research Center at Roypuram, a recipient of Vocational Excellence Award from Rotary Club, and I can vouch for everything. Known Jayashree for a very long time, from the time she was a student, just absolutely a brilliant person. Next slide, please. Chitra Selvan, Associate Professor of Endocrinology from MS Ramaya Medical College, Bangalore, A.V. Gandhi Award for Excellence in Endocrinology, RSSDI Young Investigator Award. If I can just tell about Chitra in one line, the future of endocrinology in India is safe. Next slide. Dr. Belinda George, Associate Professor, again from Bangalore, from the St. John's National Academy of Health Sciences. Recently published work on riding high on low fuel, on hypoglycemia, and again, a very, very bright upcoming endocrinologist. And again, I can add that the future of endocrinology in India is very, very safe with these beautiful women. Next slide. And coming up, another beautiful woman, endocrinologist from Mumbai, and full of energy, very active in the Endocrine Society, and very active in research with special interests in PCOS and gestational diabetes and osteoporosis. Next slide. And Aishwarya Krishnamurthy from Delhi. Aishwarya is actually a Chennai girl, but presently in Delhi. Chennai girls rock, I have to tell you. Pramila Jaipal is from Chennai. We may have a vice president in the US who's from Chennai, Kamala Harris. So all I have to say is Chennai girls are rocking. So Aishwarya Krishnamurthy is at the Max Super Specialty Hospital in Delhi. Very, very active in research and teaching. Another very spirited young endocrinologist from India. Next slide, please. So that takes us to Professor Mark Molitch and the keynote address on prolactin and its clinical significance. Mark?
Can you unshare your screen? And then I can share. Okay. Well, thank you very much for this very kind introduction and invitation to speak to you this evening. So I'll be very briefly reviewing hyperprolactinemia. And so to look at the clinical prevalence of pituitary adenomas, these are series from a number of countries around the world, showing that the overall clinical prevalence is about 1 in 1,370. And if you look at the distribution of the types of pituitary tumors, you see that prolactinomas make about 50% of these tumors, with lesser amounts for non-functioning tumors, growth hormone and ACTH secreting tumors. So to review the regulation of prolactin very briefly, remember that the hypothalamus regulates the pituitary secretion of prolactin, with positive from TRHN vasoactive intestinal peptide and negative via the neurotransmitter dopamine. And the dopamine is the dominant factor here, so that there's an overall inhibition of prolactin secretion by the hypothalamus. So that if you cut the hypothalamic pituitary stalk, you then have a rise in prolactin secretion via getting rid of this dopamine. There are a number of receptors on a variety of tissues. We're familiar with the breast, so that prolactin stimulates milk production in the puerperium. There are spinal afferent pathways going from the nipple back up to the hypothalamus and from the chest wall, so that suckling will stimulate the release of prolactin through the hypothalamic pathways. There are also direct effect of estrogens on stimulating the growth of lactotrophs in the pituitary, and the very high estrogen levels during pregnancy stimulate lactotroph hyperplasia during pregnancy, and we'll come back to that in a few moments. So the main symptoms that patients present with hyperprolactinemia are for women amenorrhea and galactorrhea, and for men erectile dysfunction, rarely galactorrhea, headaches and hypopituitarism and visual field defects, mainly from the large size of tumors that tend to be present in men, although women certainly can have large tumors as well and have these mass effects as well. But if you see galactorrhea in a male, it's almost always due to a prolactin secreting tumor. So the mechanisms by which we see this interference with gonadal function is predominantly here at the hypothalamic level, where hyperprolactinemia increases the peptide kisspeptin, or rather decreases kisspeptin, and that therefore decreases the pulsatile secretion of gonadotropin-releasing hormone, which then has its effect on the pituitary to decrease the pulsatile secretion of FSH and LH, causing the hypogonadism. There's also an interference with the positive estrogen feedback at mid-cycle. There's an inhibition of aromatase activity in the ovary, and in the males, there's an inhibition of 5-alpha reductase in the testes. But the main effect here is going to be at the hypothalamic level to decrease gonadotropin secretion. So the most common cause of hyperprolactinemia is pregnancy, and so the very high estrogen levels stimulate lactotroph hyperplasia with an increase in prolactin secretion, and you see the gradual rise of prolactin levels over the course of gestation to levels close to 200, which is levels that you really only see with prolactin secreting tumors generally. There are a number of medications that can cause hyperprolactinemia, and these operate primarily by causing a decrease in either dopamine secretion by the hypothalamus or by dopamine action at the pituitary level by blocking the dopamine receptor. The most common cause are the antipsychotic agents, the atypical antipsychotics like risperidone, but there are a number of other drugs that we commonly use like metoclopramide or domperidone that can also cause a rise in prolactin levels. So the important thing is to take a careful history when you have a patient with hyperprolactinemia to make sure they're not taking one of these medications. With respect to the pathological causes of this, we certainly have prolactinomas. About 40% of patients with acromegaly also have co-secretion of prolactin. Other hypothalamic disease, either from other tumors or infiltrative disorders of the hypothalamus like sarcoidosis or stalk disease like hypophysitis, these decrease dopamine coming down from the hypothalamus to the pituitary, resulting in mild to moderate hyperprolactinemia. With hypothyroidism, you have an increase in TRH and an increase in sensitivity to TRH causing hyperprolactinemia. Rare causes include chest wall trauma stimulating those neurogenic pathways. And finally, with renal insufficiency, you have both a decrease in clearance of prolactin as well as an increase in secretion of prolactin. Now, with respect to the circulating forms of prolactin, the monomeric prolactin is 23 kilodaltons. There are some glycosylated forms. And then most importantly, there's also macroprolactin. And most of that is due to a binding to IgG, which accounts for most macroprolactin. There may be some heteromers as well. And importantly, this macroprolactin that's in the circulation is less biologically active than monomeric prolactin. And in some individuals, there is a very high level of macroprolactin that interferes with the immunoassays that we generally use for measuring prolactin. So the important thing with respect to macroprolactin is that it's usually often found in patients that only have very equivocal symptoms, such as orgasmic dysfunction, that type of thing, and then the prolactin is found to be elevated, and this is may often be macroprolactin. So it's important to not measure prolactin unless the patient is truly symptomatic. If you think that macroprolactin may be the cause, then you can have the laboratory do a precipitation with polyethylene glycol and then look for what's still in the supernatant to see if monomeric prolactin is indeed still elevated. If the proportion of monomeric prolactin is still elevated, then you just treat them like any patient with hyperprolactinemia with the evaluation and treatment. If the patient's symptomatic, they may need to be treated. And again, you have to exclude other causes, measuring TSH, creatinine, and maybe doing an MRI scan. And then finally, if the patient is symptomatic, then a therapeutic trial of a dopamine agonist may be warranted. The other interference with prolactin measurements is very high levels. And so if you have a very large tumor making very high levels of prolactin, such as they might turn out to be 10,000 or 50,000 nanograms per ml or micrograms per liter, these may result in just showing up to be a normal or slightly elevated prolactin because the antibodies in these two-site assays can be saturated by these very high levels. And so if you have a patient who's got a large tumor greater than 3 centimeters in diameter, and the prolactin levels are only normal or slightly elevated, then you should remeasure these undiluted and 1 to 100 dilution to make sure it's not hyperprolactinemia from the tumor and not just to a non-functioning tumor that's causing that stalk effect with just a mild elevation of prolactin. But that's really the only time that you would look for this hook effect with very large tumors. So then just to summarize here, we need to take a careful history regarding medication usage, examine the patient looking for galactorrhea. Laboratory testing would be a pregnancy test, thyroid function, creatinine, and then doing an MRI to look for a tumor. And again, just because a tumor is shown doesn't necessarily mean it's the etiology of the hyperprolactinemia. You can have a non-functioning small tumor in the patient taking risperidone, which might be the cause of the hyperprolactinemia. Visual fields are only necessary when the MRI shows that the optic chiasm is being compressed. And again, think about the hook effect if it's a large tumor with only normal or mild elevations of prolactin. The treatment of prolactinomas is by and large using a dopamine agonist, and they are certainly the preferred modality because of their high efficacy. You can normalize prolactin levels and achieve remission of associated symptoms in 80 to 90% of patients with cabergoline and 70 to 80% with bromocriptine. And you can also reduce the tumor size, and this occurs in over 80% with cabergoline and over 60% with bromocriptine. And by reducing tumor size, sometimes you can restore anterior pituitary function that might have been low because of the large tumor size. In addition, you can continue these drugs. You can prevent tumor disease recurrence or progression. In some cases, perhaps 10 or 20%, you can sometimes withdraw the dopamine agonist after a couple of years of therapy. And surgery really needs to be done in certainly less than 10% of patients. These are the data if you decide that surgery is needed for a patient. And so for microadenomas, the initial normalization rate for expert surgeons is in the 80 to 90% range. There's a recurrence of about 10 to 20%, with a long-term normalization, therefore, of only 60 to 80%. For macroadenomas, the numbers are clearly much lower, and depending upon the size and invasiveness of the tumor, the cure rates are substantially lower, again, with that 10 to 20% recurrence. So the long-term normalization rates are really quite low. But again, these are data with the expert pituitary surgeons. So the indications for surgery would be a visual field defect that's not responding to medical therapy, a macroadenoma. If it's stable on medical therapy, then that's probably okay. But if it's still growing, then I think that would be an indication for surgery. A patient who's intolerant of dopamine agonists, that may be a reason for surgery. The patient that has pituitary apoplexy with a sudden hemorrhage into the tumor causing a sudden headache and vision problems and hypopituitarism, that may be a cause as well. And finally, CSF rhinorrhea, that's due to a prolactinoma eroding into the sphenoid sinus, may be a reason for surgical repair of that leak. Radiotherapy is very rarely done for patients with prolactinomas, and it really would be due to a patient who's got continued growth of a prolactinoma despite medical therapy and surgery, and the patient's got persistent symptomatic hyperprolactinemia, again, despite medical therapy and surgery. About 15 to 20% of patients don't normalize their prolactin levels with conventional doses of cabergoline. And if this is the case, then there are other options. So one possibility is to switch to another agent so that the patient actually is on bromocriptine. About 50% of those that are resistant to bromocriptine will then respond to cabergoline. We don't really know the converse very well. There are rare patients that are resistant to cabergoline that do respond to bromocriptine, so that's worth a try, but we really don't have good data in that regard. You can also increase the dose of cabergoline as long as it's tolerated, and as long as you continue to get a stepwise decrease in prolactin levels with each stepwise increase in dose. And again, these are patients where you start to think about surgery, irradiation, And for those who are interested in pregnancy, we need about thinking about alternative methods of inducing ovulation. Well, this issue about using larger doses, there's a risk then for heart valve abnormalities. Here we see data in patients with Parkinson's disease who are generally treated with more than 2 milligrams per day rather than 2 milligrams per week. And we see that in patients taking cabergoline that there's a very high percent who develop a cardiac valve abnormalities. This is also seen with pergolide. It's not really seen with bromocriptine. So the issue then comes in the patient who has a prolactinoma that's resistant and needing more than 2 milligrams per day. What is the risk for development of cardiac valve abnormalities? There are a number of series in the literature now looking at patients treated with cabergoline at less than or equal to 2 milligrams per week, sort of the conventional dosing. And there really is no increase in cardiac valve abnormalities in these patients, again, taking doses less than 2 milligrams per week, except for this one series in which the cardiologist reading the echocardiogram was not blinded to the treatment group. So your patient who clearly has getting more than 2 milligrams per week, I think that they are at some risk. And so we need to inform that patient of potential risk at their next visit. Those who are on conventional doses, I don't think they are at increased risk, and they can be reassured and should not have echocardiograms unless they have symptoms, or of course, if you hear a murmur on your examination. But those who are more than conventional doses, that is more than 2 milligrams per week, I think there's an increased risk, although I don't know where that risk starts. So in these individuals, I get an echocardiogram, and depending upon the outcome of that study and the dose and how much you're going up and how long they've been on it, you may well want to repeat studies in the future. There are some other adverse effects that we need to talk about of dopamine agonists. And the first of these is the impulse control disorders. And these are commonly seen again in Parkinson's disease patients who are on dopamine agonists. And these impulse control disorders consist of hypersexuality, pathologic gambling, compulsive shopping, and these actually have been reported in patients taking dopamine agonists for hyperprolactinemia. There was a recent study that was done from Turkey of 308 patients with prolactinomas, and 17% of these had impulsive control disorders. Hypersexuality was the most common one of these, but other ones occurred as well. And again, these are more common in men. And I've certainly seen this in several men. And I think what you need to do is you need to warn patients and just give others or other family members about this potential adverse effect. And you really need to ask about this at subsequent visits. Now, these can be hidden. The compulsive gambling and shopping may be hidden from family members, and you need to probe this a little bit on your visits with your patients. And then the other complication is CSF rhinorrhea. Again, if you have a large invasive skull-based tumor, it kind of serves as a cork in the base of the skull. And so if you shrink that cork with a dopamine agonist, then you can have a CSF leak. And so this is a patient who's got a watery discharge. The patient leans forward. This will increase the amount of fluid. And a major concern here is that you've got an open passageway here for bacteria to go from the nose back into the brain that might cause meningitis. And what you do is you need to measure this with beta-2 transferrin in the CSF. And this is found, a protein that's found only in CSF and not in nasal mucus. So that's the diagnostic modality. And if that is found, then the patient needs to have a surgical repair of that passage to prevent the meningitis from occurring. And then finally, we come to prolactinomas and pregnancy. And remember, as I mentioned before, prolactin levels will increase during pregnancy, and pituitary size itself will increase due to lactotroph hyperplasia. And the concerns that we have might be that those due to a dopamine agonist use. Is this a safe thing to do during pregnancy? Remember, we needed to allow ovulation to occur. And it turns out that it actually is very safe. With bromocriptine, we have data in over 6,000 patients. With cabergoline, data in about 1,000 patients. And there's no increase in malformations or other adverse outcomes with either of these medications. The other possibility is that this high estrogen levels can cause an increase in tumor size. And the data show that for microadenomas, the increase is about 2.5% of patients. With macroadenomas, it's about 18% of patients. And so if we generally stop the drug after the pregnancy starts and ovulation and the pregnancy is confirmed. But if the tumor increases, you can reinstitute the dopamine agonist. And if the patient doesn't respond to the dopamine agonist, then surgery may be needed. And again, this is only for increasing headaches or vision disturbance that you would intervene in a patient like that. Of course, if it's late in gestation, say 37, 38 weeks, you might well consider delivering the baby. And then finally about nursing, nursing does not make tumors get bigger. And so that there's no problem as far as nursing in a patient with a prolactinoma. But of course, you should not restart the dopamine agonist in somebody who wishes to nurse because that will suppress prolactin and breast milk secretion. So you need to hold off until the patient is finishing nursing before deciding about whether dopamine agonist needs to be restarted in a patient like that. Well, thank you very much for your attention. And I think we'll move on to continue with the program. Thank you.
Thank you, Mark. Jayashree, you can take over from.
Thank you very much, Professor Molitch. I mean, as usual, every slide gave us something to think about. I'll just move on to my first question. Can you show the next slide, please? Yeah, so we are seeing a lot of people who present to us with pituitary incidentalomas, and there's been a lot written about it. But really, I think the question here is at what size of tumor do we need to start evaluating? Do you have a size cutoff, 3 millimeters, 5 millimeters? At what size do you evaluate them for hormonal issues, Professor Molitch?
Well, even with relatively large microadenomas, say those around 6, 7, 8, 9 millimeters, there can be start to be an increase in hypopituitarism, but the common hormone lost is that of growth hormone. So that if you think you're going to treat with growth hormone, if you find a deficiency, then you would evaluate that. The loss of other hormones is much less than growth hormone. And obviously ACTH and TSH will be the most important ones clinically. So that, a quick screening of an AM cortisol and an AM free T4 level would be reasonable to screen even in those patients, but I probably wouldn't go further in that.
So sorry, is there like a size cutoff that you mentioned or?
Yeah, probably 6 millimeters or greater. Okay.
And how about the reverse, Professor Molitch? I mean, what are the tests you would recommend to, I mean, you talked about the hypopituitarism. How about the things that you do for the over-secreting or making sure it's a non-functioning pituitary adenoma?
Right. Well, I mean, obviously prolactin is very simple to do. We will often do either a late night salivary cortisol or an overnight 1 milligram DEX suppression test and an IGF-1 in those patients if there's any even minimal suspicion that it might be secreting.
And I also had another question. So when you see someone like this, when do you recommend a repeat MRI and when do you recommend a repeat endocrine evaluation?
Well, for the microadenomas, we repeat MRIs once a year, for a few years. If there's no change in size after 3 or 4 years, then we would go to every 2 or 3 years in evaluating them. For the macroadenomas, if we decide that we're not going to treat and find no hypopituitarism, I probably would continue to measure those every year, probably out to at least 5 years, and then go to every 2 years after that. I don't repeat the pituitary hormone evaluation unless I see a size change.
Okay, that's helpful to know. That's helpful to know. Thank you.
Mm-hmm.
Anything else, Usha? Anything you want to add or ask, or can we move on to the next question?
No, I think Professor Molitch has answered this extremely well. Just from the history, if they're menstruating regularly, I mean, I'm not at all worried about any issues with gonadotropins or anything. So just like he said, probably overnight DEX suppression, and because salivary cortisol is a challenge in India, we don't have it freely available everywhere. So just an overnight DEX suppression and IGF-1, and that's about it.
Yes,
and
I agree. Yes, of course. I agree. Yeah, that would be sufficient.
Can we move on to the next question? This is for Dr. Uma. Uma, a 32-year-old lady who presents with a relatively recent onset of menstrual irregularities from the age of 29. She had her children at the age of 24 and 27, and her weight gain actually began after this. The BMI is currently 30. She is diagnosed as PCOS and started on metformin. And in your opinion, do you think she has PCOS?
Okay, thanks, Jayashree. I would actually ask her a little bit more information about her cycle patterns in her adolescence and before her children were her pregnancy spontaneous. Did she need any ovulation induction? Now, if she has had menstrual irregularities only since, it says here 29, which means that she's started having her problems after she's completed her childbirth, possibly something to do with the fact that she has gained weight. So she has anovulation, but I don't know if I will label her as PCOS just because her cycles are irregular. Because most of the time, if they have a polycystic ovarian syndrome, very often there is a history of irregular periods and some anovulatory cycles in the past. So somebody like this, it could be that the weight gain and the obesity has induced insulin resistance, and that insulin resistance is causing anovulation. So unless we have other, I mean, you know, if you go by the criteria, if there's no evidence of any hyperandrogenism, and if her ovaries are looking okay, I don't think she needs that label. But I will still address weight loss, lifestyle, and emphasize to her that that is probably what will help her regularize her cycle.
Thanks, Uma. I think part of the reason this case was put up is quite often any irregular period, like you pointed out, is labeled as PCOS. And I think what is important here is that she started having her menstrual irregularities at the age of 29, and we have to rule out other causes. We have to go through the
thyroid also, you know, I mean,
thyroid,
she could have thyroid dysfunction, and that could cause. So I would do a full work, you know, evaluate all other causes for irregularity.
Yes. And as an endocrinologist, you know, we would start thinking about other things, cortisol. We just go through that. We like to look at it. So we go through the whole you know, gamut before we would label her as, like you said, the weight gain, insulin resistance causing PCOS like picture.
Yeah.
Yeah.
Anything to add, Usha, Professor Molitch?
This is such a common, you know, presentation in our clinic, and because about 25% or so of normal women are supposed to have polycystic appearing ovaries on ultrasound. It's really easy to connect the dots. Somebody with irregular cycles, also with polycystic ovaries on ultrasound, and then call them as PCOS. And I think as we come to some later discussions, if we do label someone as PCOS, I think we have to take care of them, you know, a lot more differently and, you know, and intensely. So labeling someone as PCOS may also give them a lot of psychological stress.
If I can just add, very often, as you have put here, the label is already given. So
Yes.
when they come to you and you're trying to tell them that, you know, this may not be that,
yeah,
and then motivate them to try and exercise and lose weight, that's a fairly tough ask, in the sense that it takes a lot to convince the woman. So I think it is better that we don't stick these labels unless we are quite sure.
Yeah, in fact, this is a real patient that I saw, and my knee-jerk response was, no one gets PCOS at 30. You don't have PCOS. And then I backtracked and said, no, it doesn't sound like PCOS. We need to work you up for other things. And yeah.
Can we move on to the next slide, please? Yeah, this is for you, Dr. Usha. A 37-year-old lady has amenorrhea for 80 days. Pregnancy test negative. FSH is 2, TSH is 1.8, and prolactin is 16. And this is the first time she's missed her periods. How should we proceed? And there are 4 options there. Should we wait for another few weeks to see if she's going to get her period? She's 37. Should we be trying progesterone withdrawal? Should we try HRT? Should we be thinking about a pituitary problem? Her FSH is low normal. So should we then immediately jump into imaging the SELA? What would you do in a situation like this?
So I think we need to talk to her a little bit more to find out maybe what happened just before these 80 days besides COVID and lockdown and all that. I'm just saying that anyone who presents like this, I would find out maybe there was a sudden emotional, some upsetting major event that can cause something like this. And all the pituitary hormones, the numbers can look like this. Or if, like the previous patient, if there was some sudden weight gain that happened to her, and this is an anovulation thing that is happening to her. So I think getting into her history some more, since this is the very first time. So she actually, again, came to see us thinking she's going through the menopause. Have I stopped? Everything stopped. I'm only 37, and was quite relieved when the FSH was not high. But then, what could be causing this? Could this be some major life event that happened just before this? Was there some major shift in the weight gain or loss? Suddenly, some people go on these very crazy, intense weight reduction, and suddenly if they drop a lot of weight, this could happen. Sometimes it's just an ovulation. So what I would definitely do is, after the history and careful examination, and like you said, looking for other features of possibly some endocrine problems. If I thought she looked hypothyroid, I would get also a free T4. I think just a screening TSH may miss hypothyroidism, central hypothyroidism especially. So I would think of that. And then first try, and I won't wait for another few weeks because 80 days is long enough. Usually I wait up to 60 days, but not more than that. I'm also worried about endometrial hyperplasia happening beyond the 60-day period. So definitely give her progesterone withdrawal. Like give her medroxyprogesterone acetate, 10 milligrams for 5 days, and wait for a couple of weeks to see if she has progesterone withdrawal. If she doesn't have progesterone withdrawal, then I would try HRT. And if she withdraws with HRT, then I know that she's deficient in estrogen, and these could actually indicate a pituitary problem maybe, and then consider imaging the SELA and working her up if she has withdrawal with HRT and not with progesterone. And if she doesn't withdraw with progesterone or with HRT, then I have to think in terms of something going on at the level of the uterus, like Asherman or some other pathology at the level of the uterus. So I'm saying this is how I would think. Definitely not image the SELA. Takes us back to Dr. Molitch's description when we talk about the incidentaloma. We don't want to pick up something and then blame that as the cause of all this.
So, yeah. I just wanted to ask you, Usha, what if this lady was 42 and what if she was 45?
So at 42, definitely we would be working her up because it's still, even early, menopause. Even at 45, I would get an FSH, just an FSH. And if FSH came back normal, then again, some flags are going up because maybe it's perimenopause, maybe menopause transition, and just try progesterone withdrawal.
So quite often I see some gynecologists when they present at the age of 45 with pictures like this, I mean, I think if I see an FSH of 2 in a 45-year-old lady, I would want to monitor her because, you would expect a higher FSH at that age. But I just want to mention that because quite often women, even in their mid-40s, are put on hormone replacement therapy or contraceptive pills, without consideration of all of their other risk factors for metabolic consequences from HRT. So I think it's important, like you said, that we evaluate them, look for other reasons why she may be missing a period before just putting them on something like a contraceptive tablet just for the sake of getting a period.
Yeah, oh, definitely. Yeah.
Yeah. No, I agree, Jayashree. I just wanted to add that if she was 45, then one of the things I would do in addition to decide whether to give her progesterone withdrawal or just wait, because at that age, many women are reluctant because they think it's menopause and they don't particularly want to induce a bleed. I tend to do a transvaginal scan because we have the luxury of doing it in our clinic, assess the endometrium. If in 80 days that endometrium is thick, then it gives me a reason to tell her why the withdrawal is important, because otherwise she's going to have a menorrhagia, at whatever point she has a breakthrough with a bleed. If it is thinned out and her FSH is just, if it's thinned out, then I'm not particularly worried about giving her progesterone withdrawal, but I'm interested to know whether she's heading towards menopause. And if her FSH was 2, then I'd probably give one of you guys a call and say, hello, what do I do? Do I just wait or do I see her again? Because, we need to keep an eye to see what's going on.
Mark?
Do you ever measure estradiol level?
Not often. As a gynecologist, I don't do that often in this age group.
I mean, if it came back very, very low, then you know that you're not going to have any result from your progesterone withdrawal.
True.
Anything else, Dr. Usha, or can we proceed?
Yeah.
Okay, the next slide.
Okay.
It's over to you.
Yeah, thank you. Thank you, Dr. Jayashree. Thank you, Professor Molitch, for that beautiful talk. And this case is presented to you to help us try and figure the situation out. So this lady's situation is very similar to the previous case that Dr. Jayashree presented. She's 36 years of age. She's had amenorrhea for 4 months now. And on evaluation, she was found to have a low LH, a low FSH, and a prolactin of 6. She also brought in a thyroid function test in which the TSH levels were normal, but the free T4 levels were low. And she wasn't forthcoming with this bit of history, but she's noticed increased thirst. She has to interrupt her work every hour or so to get a sip of water and also make a visit to the restroom. An imaging of the cellar was ordered, which showed thickening of the pituitary stalk, and a diagnosis of lymphocytic hypophysitis was made. So my question to you, Professor Molitch, is what's the natural course of this condition? And I'd like you to particularly address the use of steroids in the role of an immunosuppressant with the intention of normalizing anterior pituitary function. Is that something you do? What do you follow in your practice?
Well, first of all, I'm not sure I necessarily buy the diagnosis of lymphocytic hypophysitis. That could well be the diagnosis, but the thickened stalk without any changes in the pituitary can be other things as well. It could be sarcoidosis. It can be histiocytosis. The histiocytosis from Langerhans cell histiocytosis can be a dysgerminoma. So there can be other possibilities. And so I would make sure that those have been excluded if possible. It's not always easy to exclude those things. And if you can't exclude those with other testing and you still have a differential diagnosis that just goes on, sometimes we just follow those patients along. If it is hypophysitis, it may just persist like that. You may have a gradual resolution of the thickening of the stalk, but then the hypopituitarism usually persists. I'm surprised that the prolactin level is not higher because you have evidence of diabetes insipidus as well. And so that in those cases, prolactin levels are usually high from lack of dopamine getting down to the pituitary. So if the patient has hypothyroidism and low cortisol, then those need to be treated, especially the low cortisol, which is potentially life-threatening. And so we always have to treat the low cortisol. As the case evolves, assuming it is hypophysitis, it's pretty rare for the hypopituitarism to resolve. And usually that's a permanent finding. It can resolve, you do have to look for it, but it's uncommon to do so. Again, we treat the patient's hormonal deficits, looking for a possible resolution over time, but being pessimistic that that's going to occur. So the issue that comes up as to whether using high-dose steroids to treat the immune situation causing the hypophysitis. And there are no prospective randomized studies using this. And I think most of the time, I certainly don't use high-dose steroids in a patient like this. And the only time I would use this if a patient is really having recurrence of problems, having very large mass effects where you're concerned about this. The high-dose steroids are of uncertain benefit in most cases. There are clearly some cases where you have a lot of pituitary enlargement, you treat with high-dose steroids and it gets smaller. And so that, in rare cases it can be benefit, but then that even still doesn't cause a reversal of the hypopituitarism in almost all cases. So I think using high-dose steroids is rarely needed.
Thank you. Thank you.
Use high-dose steroids.
Thank you for that answer, Professor Molitch. If I could just bring you back to the narrowing down the diagnosis of lymphocytic hypophysitis, because that's a diagnosis which we make after, let's say, a biopsy is done. So if you're trying to exclude other causes of hypophysitis, what are the most common tests that you are likely to order? You did mention sarcoidosis. In India, tuberculosis is very common. You did also. And the new entities of hypophysitis like IgG4 related hypophysitis are new as well. How is that evolving in your clinical practice? Do you routinely ask for serum IgG4 levels? How is that panning out in your practice?
Well, I mean, we would do that if the pituitary was involved. I've not seen cases of, or at least read about IgG4 or plasmacytic hypophysitis solely confined to the stalk. And so that would be my concern here. If we do see a patient with looks like hypophysitis based on the MRI finding as though the pituitary, the sort of diffuse enhancement, then we do tend to measure the IgG4 and look for plasmacytes, increased plasmacyte in the peripheral circulation as well.
Okay, thank you, Professor Molitch. Dr. Usha, Dr. Uma, do you have any thoughts to add to the situation?
I think you asked the question I was going to ask, which is, this making the diagnosis is somewhat, so tricky, and lab work like for a dysgerminoma or for eosinophilic granulomatosis or sarcoidosis, all of those things. I'm just saying that we do some baseline, some tests, but I think we kind of come back to this diagnosis when those things are not clearly obvious. I don't think we make this diagnosis with histologic diagnosis.
Correct.
I think it's very difficult in some cases, and I'm sort of hesitant to, if all we have is a thickening of the stalk and hypopituitarism, and there's no other lab evidence, liver function tests or chest X-ray diffusion capacity, things like that. If there's no evidence of anything else and we just have the stalk thickening, I'm sort of hesitant to want to do a biopsy because you could certainly cause permanent stalk damage from the surgery. So I just sort of follow those patients along.
Mark, I have a question. So after some time, do you start like pulling back on the hormones to see if the pituitary function has recovered?
I do, but it's rare for that to be the case.
Thank you.
Thank you, Professor Molitch. Thank you, Dr. Usha, for that beautiful interaction. Could we move to the next case, please? Okay, this is to Dr. Uma Ram. So, ma'am, so we have young adolescent girls presenting with anovulatory cycles. So, oligoamenorrhea followed by a cycle which has menorrhagia. So, when do you actually suspect PCOS in this situation? And if you have a child or an adolescent vacillating between oligoamenorrhea and menorrhagia, what do you usually initiate? Are you likely to have progesterone withdrawal like you showed us in the previous case, or are you likely to choose OCPs, or are we just going to fall back on lifestyle changes in metformin? Over to you, Dr. Uma.
Okay, so thank you. This is another area where we are seeing increasingly more and more adolescents who come to us with menstrual irregularities. And again, here we need to be conscious that there are other reasons for menstrual irregularities than just PCOS. Increasingly, many of them are labeled as PCOS. They sometimes come themselves and say, I have PCOS. And we then have to work our way through the issue. So how old is she? I mean, is she, 13, and when was her menarche? And I think these are two important questions to ask, because it can take a couple of years for the cycles to settle. Of course, increasingly, we are having these kids start their menstruation from, say, 10. So even when they come to us at 14 with this kind of irregularity, they say we've already had it for 4 years or so. So what was the age of menarche? How was the cycle pattern before? Has it always been irregular? Has it become irregular now? And again, what is their level of physical activity? What is their height, weight, BMI? Are facts that we need to keep in mind. And before we say PCOS, of course, hypothyroidism needs to be ruled out. You need to look for other causes. And if, particularly in the adolescent, you can have an ovary-looking polycystic. You can have you can have acne as a part of their pubertal changes. So there has to be some overt or definitive hyperandrogenism in addition to the menstrual irregularity for you to stick that label. So we need to have, we can't just, we have to be more careful about the criteria when we say that an adolescent has PCOS. And then coming to the treatment, right? Yeah, so what do we do in general if most of them we do find have issues where they are overweight or obese, and I tend to ask them to address weight and lifestyle as the first step. And while they're doing that, discuss progesterone withdrawal only as a means of reducing the menorrhagia that happens. Because if they repeatedly have a period only after 3 months or 4 months, and then they bleed heavily, then it's a cycle that we are chasing. So at this point, usually give them withdrawal if they don't get a period in, say, 60 days, but emphasize lifestyle changes, diet, exercise. Have somebody walk them through what they need to do. And if they are willing to engage with the dietitian or somebody who can give them lifestyle advice, do that. And then have them come back in, say, 4 to 6 months to see how they're doing. I think that is important, because otherwise they tend to go back and just have the progesterone withdrawal and don't do anything else. And that progesterone withdrawal, or even if it is the birth control pill, is not going to correct their baseline problem. And I think that is information that we need to give both the adolescent and her mother, that this is not a one-time solution. This is potentially a problem that they have to deal with over a period of time.
Thank you, Dr. Uma. So the diagnosis of PCOS in adolescents is different in that we are not going to rely on the ovarian ultrasound findings. We are going to be using the anovulatory cycles, but the duration has to be at least 2 years separated from the age of menarche.
Yes.
And you're also trying to have acne and hirsutism, which is, how is that different in adolescents, Dr. Uma?
No, I mean, what I'm saying, that you can have acne as a part of normal puberty. So you don't take that as an evidence of hyperandrogenism. You either have to test and show biochemically that there is hyperandrogenism, or obviously if they have a lot of hirsutism, but we don't see that in our population in general. Right. I don't know if when we see our adolescent PCOS, we don't see too many who have overt hirsutism. So many of them are labeled just based on the acne, and that is something that we should try and be conscious of.
And the physiological puberty-related anovulatory cycles are most likely to settle down by about 2 years since the onset of
a couple of years, yeah.
Yeah, so that should be the time when you maybe need to rule out secondary causes, as you pointed out, hypothyroidism. Dr. Usha, would you want to add anything to the conversation?
This is another tricky one where, you know, like you said, the puberty itself can cause acne and stuff like that. And their cycles can be regular just on the basis of, you know, early in puberty, if they are early in puberty. And they may not have any polycystic ovaries on ultrasound, because that's also evolving. So this is one area where I know that they can have normal ultrasound and then evolve into a polycystic ultrasound. But one more thing that I have started doing is looking at the metabolic abnormalities, looking at lipids and looking at glucose for sure with 75-gram GTT, and also at liver enzymes. And if I find these abnormal, I think that is, to me, a strong indication of polycystic ovary syndrome. And a little bit of history as well, low birth weight, you know, some premature adrenarche, things like that, or a family history. So that's what I would do. And I totally agree with Uma about, you know, approach to these girls is especially tough when if you're thinking in terms of, because the first question they ask me is this a hormone you are prescribing? And I usually tell them, I'm an endocrinologist, I only prescribe hormones. So yes, it is a hormone, but whether it's a progesterone or whether it's an oral contraceptive pill, that's the tricky one.
Correct. Yeah. All right. Professor Molitch, would you like to add something?
No.
Thank you. We'll move on to the next scenario for Dr. Usha. So, ma'am, when should we consider treating subclinical hypothyroidism in non-pregnant women? And should we routinely screen for thyroid during preconception care? And in the preconception window, how will you treat subclinical hypothyroidism differently if you find a biochemical value would suggest that?
So should we consider treating subclinical hypothyroidism? So first thing is subclinical hypothyroidism is when you have a TSH more than the upper limit of normal and below 10. And when the T4 is normal or free T4 is normal, but TSH alone is elevated. So this can happen for a lot of reasons. It can just be in the early part of hypothyroidism that's happening, or it can be because someone has been, someone is recovering from a thyroiditis maybe. It can be, just as people age, people, older than 70, 80, 90, as they get older, the TSH levels start going up, into this range. So it depends a lot on the age of the woman. I would definitely look into that. And then, of course, if they are interested in fertility, I'm definitely looking into that. So if it is just a laboratory test that has been done because she went for some mastered health checkup or some assessment, and this TSH abnormality came up, then we have to seriously consider how old is this woman? Does she have any underlying medical problems? Does she have any symptoms? Is she on any medications? So look at all of those things. And if none of those are there, I would get a anti-TPO antibodies, because I want to find out if thyroid autoimmunity is there. Because if the autoimmunity is there, then I know that the TSH is likely to go up higher sooner, or over a period of time, a lot more greater chance of it rising into overt hypothyroidism than someone without antibodies. So that is the only other thing that I would consider. Of course, there are other reasons besides thyroid that can make the TSH go up, like even adrenal insufficiency, heterophile antibodies, Professor Molitch's area, TSH producing pituitary adenomas, where they usually the T4 and T3 will be elevated. So we really need to look at what else could be causing this TSH elevation if the person is symptomatic, that is, or if there is some other concern about the TSH, to treat or not to treat. So after having done that, I think the next step is, is this subclinical hypothyroidism, is it a problem? Does it cause problems? So what it has been shown is, I think, in younger people, when they say someone under 65 is young, I'm very happy. In younger people, it has been shown to increase. We'll make it, as we get older, we'll raise the bar.
Yes.
And keep going. So what they've shown is a slight increase in cardiovascular risk in younger people, but not in older people. So the current recommendation is, if the TSH is more than 10, you treat. Even that, I would be very careful. If it's a 85-year-old with a TSH of 11 doing great, I wouldn't touch it. So if it is more than 10, you treat. If it is more than 7, between 7 and 10, in a person who is under 65, the current recommendation is to treat, because you decrease the risk of cardiovascular disease. But if it is between like this upper limit of normal and the 6.9 or 7, I really think that you can wait and watch, because one of the other reasons where TSH goes up is obesity.
True.
And people come to see us thinking that TSH is making them overweight. And I have to give them the bad news that the overweight is making the TSH go up. And let's try weight reduction and repeat your TSH levels. And in many it comes down. I think there's even for every like a half a kilo weight gain, TSH goes up by 1. So people may have just gained 3 kilos or 4 kilos, 2 kilos, and then the TSH goes up. So that's another thing I would consider. But this whole preconception area, women in their reproductive years, or women having some fertility, considerations, issues like assisted reproduction and ovulation, I think they should be treated and their TSH brought to a level of ideally below 2.5, so they're ready for pregnancy. I would definitely consider that in them. Women with frank overt hypothyroidism have a lot of menorrhagia and menstrual irregularities and all that. usually milder subclinical, there's not much of an issue. And one other area is cognitive function. So what they've shown is in people with subclinical hypothyroidism, they may not have very serious cognitive decline, but some verbal memory issue may be there, is what they're talking about. So when you take a history and you find out that these are issues for the patient, if the patient complains, I'm having verbal memory issues, then you could try it. So, so in a non-pregnant patient, seriously take into account age of the patient, seriously take into account symptoms, and seriously take into account their desire for fertility, and if they're having any reproductive issues. But otherwise, I would be very careful about, jumping and treating. You can wait and watch. Just do antibodies and repeat the level in a few months. And if you see a tendency for it to rise, if a 6 went to a 9, I'm not going to wait for it to go above 10. I might choose to treat it.
Great.
So, and should we screen for in preconception care? I'm a big proponent of preconception care, though this is not part of any guideline or recommendation to do a TSH in a woman who's getting ready for pregnancy. For everyone, at least we should do targeted screening. Family history, thyromegaly, issues like that. Anybody who's definitely on thyroxine or treated for thyroid disorders, they should all be screened preconception.
Would you treat subclinical hypothyroidism targeting dyslipidemia, Dr. Usha?
No.
a lot of thought, but the simple answer, no.
Thought went into it because though it does come down, the lipid levels will come down, it hasn't translated into hard CV benefit.
Professor Molitch, would you like to add to anything that Dr. Usha has shared with us?
No, I agree. I tend not to treat subclinical hypothyroidism in most patients if the TSH is less than 10, and follow them. If it's clearly rising, then that might be a different issue, especially if they have positive antibodies. But many times it returns back to normal again if you follow people over the next year or two. I don't usually treat those patients. And again, symptoms of fatigue or weight gain are really not compelling symptoms to treat subclinical hypothyroidism in my experience.
Thank you. Thank you, Dr. Usha. Thank you, Professor Molitch. Over to Dr. Belinda George.
Chitra, if I can just add.
Sure. Sorry, Dr. Oma, sorry.
No problem. Yeah. Because you asked the question about testing routinely in the preconceptional care, I just wanted to say that in our, we've looked at about nearly 5,000 patients over the last 4 years, at booking TSH. Because many don't come for preconceptional care. So when they come in early pregnancy and we book, about 1% have overt hypothyroidism. That is, they have a TSH of greater than 10 when they book.
Right.
And these are women who we would definitely treat. So that's roughly the kind of numbers that we are seeing. So I guess it is worth it if we had known earlier to have treated them. It's just a different way of looking at it. If we, because we don't have routine screening otherwise, many of these young girls don't go into, have their tests done. When they come, it's an opportunity for us to screen them.
Right.
We may not want to treat the subclinical, but we may pick up an overt hypothyroidism there, especially if they're planning pregnancy and they come to you for preconceptional advice.
So I think the two questions were, so in non-pregnant women, the situation is different, but of course in the preconceptional age, we would treat even subclinical hypothyroidism as clearly mentioned by Dr. Usha. Thank you, Dr. Oma, for that input. Dr. Belinda George, over to you.
Thank you. Thank you, Chitra. And we are down to the last 15 minutes of our Meet the Professor session. And so far, it's been a great discussion. So can I have my first slide, please? The first question is to you, Professor Molitch. Uh, when do we recommend GH therapy to adult women with hypopituitarism? And do you think GH has a role in infertility?
Well,
Professor Molitch?
let's take the second question first. There are data for going back 20 plus years ago, maybe 30 years ago, to suggest that growth hormone therapy might improve fertility even when growth hormone deficiency wasn't tested for. And I think that kind of fell out when more detailed evaluation and treatment of those women came about. So I think that that's no longer a popular thing to do, and not based on any real data to show benefit. So if you actually truly have somebody who's got growth hormone deficiency, then that really needs to be determined by a stimulation test to look for growth hormone deficiency. Then the question is whether that should be treated. And I think in most cases it should be treated. Now, we also have to take into consideration the benefits and the cost. I mean, it's a very expensive therapy, and so that it's certainly not for everybody to do this. In the US, insurance companies will cover growth hormone therapy for people with documented growth hormone deficiency. I'm not sure that's the case in India and other countries, however. So the benefits are modest, however, they're not dramatic. There are no data yet to show that it decreases mortality, which is increased in hypopituitarism. But growth hormone therapy may decrease mortality, but that's certainly far from being proven at this point in time. So the benefits are in quality of life, the relationship of fat to muscle, bones are benefited as well. But often we'll treat for a year or so and see how the patient is doing. There are some people who feel dramatically better, and you can document this in a variety of ways. And there are other patients who say, I don't notice any difference at all in as far as quality of life or mentation, et cetera, and no change in muscle strength and duration, et cetera. So in those patients, we often don't continue therapy. So the answer is yes, I do recommend it to most adult women who are documented to have hypopituitarism, but it's not a dramatic push to do that like it is obviously with thyroid or hydrocortisone for those patients with those deficiencies.
Thank you, Professor Molitch. If I can just add on to one more additional element to that question. Have you in your practice seen children who were treated for growth hormone deficiency? And normally when we transition them into adulthood, we, at least in India, 99% of them go off growth hormone therapy. So when these young women, is there a problem with their fertility? Do you think growth hormone can add value to the at the time of conception for them? Or do you think it can be an issue with infertility?
I don't know the answer to your question. I don't know that there, again, are prospective randomized studies comparing treatment with growth hormone or not treatment with growth hormone in those who have documented growth hormone deficiency with respect to fertility. I would generally treat those women. So if they're truly growth hormone deficient, by retesting again after they stop growth hormone in early adulthood. But I don't know that we have proven data to show benefit for fertility.
Thank you, Professor Molitch. Dr. Usha and Dr. Uma, is there anything that you want to add to this?
So cost is such a huge deterrent, in India for growth hormone, because most medications are out of pocket for patients. I think we have to think like 100 times before prescribing growth hormone, even when someone is frankly deficient. I'm just saying that to me that becomes the biggest deterrent, unless major quality of life issues are there. If they are replaced with all other pituitary hormones and still complain of fatigue or quality of life issues are there, and you could try this, as Professor Molitch said, for a few months to a year and see if there is a clinical improvement in that. So we need a quality of life instrument. So I'm just saying, yeah, go ahead.
I agree with you. I think the people who benefit the most are those with new onset growth hormone deficiency. So somebody, for example, with Sheehan syndrome, who you replace all the hormones, and then they still don't feel well, and you give them growth hormone, and they say, now I feel back to normal. The people who've had growth hormone deficiency for 10 or 20 years, and then you treat with growth hormone, often have very little benefit.
Thank you. Thank you, Professor Molitch and Dr. Usha. Can we have the next case, please? So, Dr. Usha Sriram, this one is for you. Here's an 11-year-old girl who was brought by her parents because of short stature. She's well below the 3rd centile for her height. And when you looked at her pubertal status, it's in stage 1, Tanner stage 1. So what should be the best plan of action for us here? Should we reassure the parents and wait till she is about 13 years to work her up further? Or do we start evaluating her now?
Short answer, I think she should have been evaluated a long time ago. That's the short answer, because for girls, usually their final height is reached within a year or year and a half of puberty. So they don't have, that window is too narrow. So she's already 11. The only thing is, of course, she's pre-pubertal. And the fact that she's short and pre-pubertal and she's 11 makes me think of things like Turner syndrome. So a good history, finding out about birth weight, because one of the things that we see a lot in India is children who are born small for gestational age and brought to us short stature and a little late, but usually they don't have delay in puberty. If anything, many of them end up having a little early puberty, the ones who are small for gestational age. So but I would still find out the birth weight and find out any other childhood illnesses and reasons, and also parental height, which is very, very important. If both parents are short and the mid-parental height is very small, then this child is also going to be, it's going to be familial short stature. So definitely looking at the mid-parental height, looking at her birth weight, and a good exam where I might find some features of Turner syndrome or features of something that might give me a clue about why she may be short and still pre-pubertal. So typically when we see a 11-year-old, we've at least started seeing, breasts at Tanner stage 2 or 3, because the average age for menarche in Indian girls is around 12, and breasts start happening about 2 years before the menarche. So we should see some breasts by this age, but it also can be some constitutional delay may be there in the child. The children who have constitutional delay will be normal height or taller. So, so I think something like Turner may be going on in this little girl. So definitely I'm not going to reassure the parents and wait till she's 13 or 14, because the window will close and we won't be able to do anything for her. We'll definitely have to work her up immediately. I would work her up with a bone age, which is a very simple thing to do, an X-ray. I would work her up with things like rule out hypothyroidism and rule out Turner syndrome. And the bone age itself will throw a lot of light on that. If it's hypothyroidism, the bone age is going to be delayed. If it is Turner syndrome, her bone age is going to be equal to her chronological age. So I might get a lot more information from a simple test like that. And some very basic evaluation like TSH and FSH might help me to make the diagnosis. If all comes out okay, and the parents are, and she's below the, she's well below the 3rd centile. So obviously she's going to be well below her mid-parental height. So we can sit down and discuss growth hormone therapy, because we only have a narrow time to take care of her. So The other thing is, of course, growth hormone deficiency, which any child who is presenting with short stature and below the third centile, that has to be worked up.
Okay, ma'am. Ma'am, if I think from your answer, it's okay to suggest that your primary issue here is height, and your all your workup is geared towards evaluating the
Yes.
cause for short stature at this age.
Yes.
So
Largely
is,
because, 11 is to me maybe a tad bit late for start of her puberty, like breast, maybe a tad bit, but it could just be, it's going to start next year. So I'm not too worried about it. I'm definitely worried about things like growth hormone deficiency, Turner syndrome, and because the window is so narrow, if we do anything about puberty, that is going to accelerate her closure of the epiphysis, and we could actually be whatever we want to do, it will be counterproductive to that. So evaluating the short stature, initiating treatment for her to do some catching up with the growth, and then think about initiating puberty, which I'm happy to wait till 13 or 14.
I think there are a couple of other issues that would be helpful. One is with the parental history of when they went through puberty and what the growth stature was. So you could have both parents say, well, they went through puberty at age 15 or 16, and they were short all their lives up until puberty. That's helpful. And then the second thing is, in this particular girl, is to look at her growth curve prior to age 11. Has she always been below the third centile, is just cruising along at that third centile level, or is she actually falling off the growth curve? I mean, falling off the growth curve, getting lower and lower, is a much more worrisome thing than somebody who's been growing along the third centile all the way along throughout her life up until that point.
Absolutely.
I think that's a very good take-home point, because if someone has started falling off the growth centile, I think it is more worrisome. They could be harboring a tumor or something which is causing that. So it's more important to evaluate them more thoroughly. Dr. Uma, is there anything that you would like to add to this?
Yeah, no.
Okay. Can we move on to the next slide then? So the next slide is to Dr. Uma. Ma'am, we know that women with PCOS are at greater risk for other non-communicable diseases. So the question is, should we consider prevention measures in these women, like for instance, statins, or should we at least start screening them earlier for cardiometabolic risk factors and even for cancer? Dr. Umara.
Yeah. So, yeah, I think, yes, definitely these women are at higher risk for NCDs, and that's something that we need to communicate to the woman, make her understand that, because very often when they come to us as gynecologists, they're only worried about their menstrual cycle or their fertility. They're not particularly worried about long-term, problems. And very often we fail in not emphasizing the long-term impact to them. And so I think it's important that we discuss the importance of preventive measures, the importance of their risk of emphasizing their risk for cardiometabolic risk is higher, and some cancers like endometrial cancer, especially if they don't have regular withdrawal and persist to have hyperestrogenism. I think it's important that we look for other cardiometabolic risk factors. See, the fact that the cycles are irregular is only one of them, or that they have PCOS is only one of them. We need to check, are they already having frank diabetes or impaired glucose tolerance? Is there hypertension? So is there obesity? What's happening? Is there dyslipidemia? So these are things that we need to actually identify, test, and then put it all together and decide what preventive measure is appropriate. For almost all of them, lifestyle is going to be an appropriate intervention. And as I said, with the adolescents, very often we give them that spiel. We tell them you need to lose weight, but they don't necessarily do it because that needs focused guidance. So we have to have systems in place where they are helped to adapt those measures, which will improve and go a long way in reducing their risk in the future. So all of them will need lifestyle. Do they need statin? I think it will depend on are there other risk factors from where they will benefit from statin. That's not a decision that I would take, but I would refer them to an appropriate person to help make that choice if there is additional dyslipidemia or familial problems of heart disease, etc. So we need to take a history of the family as well as look for other risk factors. Screening for cancers certainly needs to start, at the appropriate age, and a heightened awareness of endometrial cancer, because many of them, after they finish their reproductive, after they completed their families, they're not particularly bothered about the fact that their periods are not coming early. Very often they just let it go. And there are so many women who keep coming back to us every time for an episode of menorrhagia, and then they just go away. And in India, there is a lot of reluctance to acceptance of hormone coils like the Mirena, which at least will provide them endometrial protection. So, but I think we need to have that conversation and make them understand that they are at heightened risk, and educate them on the need to come back. And routinely screen them for even annually for their glycemic status, because we are at a very high risk of having diabetes as Indians, and if they've also had GDM and or preeclampsia, then that is a subgroup of PCOS women who I would be that much more worried about and counsel about her cardiometabolic risk. So not so much if they didn't have, even if they didn't have gestational diabetes and preeclampsia, they are at increased risk. But if they have these two in addition, then their cardiometabolic risk is significantly higher. And I think those are the women where we shouldn't drop the ball, because they have shown us that they are at increased risk, and we can use that as a means of motivating them to access preventive care.
Ma'am, just one additional point. Would you recommend any surveillance for endometrial cancer, or if the patient did not have, let's say, menorrhagia, or the patient was cycling fairly regularly?
So if they are withdrawing fairly regularly, generally we don't go in and do endometrial biopsies on these women. And there aren't any clear recommendations about ultrasound-based endometrial cutoff in somebody who is ovulating and who's not menopausal. So a lot of women are actually told that their endometrium is thick and there are implications for it, but that 5 millimeter cutoff is really only for a postmenopausal woman in the immediate post-menstrual phase, and not for somebody, where you assess a thickened endometrium when there is amenorrhea of, say, 70 days or 80 days. So I don't think there's a clear recommendation as to who we would screen for endometrial cancer if they have fairly regular cycles. But in somebody who has irregular cycles and comes to us, my threshold to sample her endometrium is going to be low. So in someone who has a chronic history of anovulation, even in the late 30s, I tend to, if they come back with repeated episodes of menorrhagia, tend to advise an endometrial sampling. And we have picked up a frank endometrial cancer in some women who are only in their late 30s. In fact, unfortunately, in 1 or 2 who have come to us for infertility. So the risk is definitely higher if their cycles remain anovulatory long.
Thank you, Dr. Uma. Professor Molitch and Dr. Usha, is there anything you would like to add to this discussion?
I think this is a great opportunity for OBGYNs who I think who are already primary care physicians for women in a lot of places to actually take this up, this prevention of diabetes and prevention of cardiovascular disease. And this is a low-hanging fruit, and we see anywhere from they say 10 to 15% of women in the reproductive age group have this issue. So huge opportunity for prevention. But then I know it needs proper guidelines and recommendations. Just an opportunity.
I think the awareness building in the OBGYN community also has to increase that these are, these women need that additional attention, because all along they are focused only on their fertility. And many times, even pre-pregnancy, a lot of things that could be optimized before they have their ovulation induction or IVF is not ideally, doesn't ideally happen because the pressure for fertility is that high. But somehow we need to communicate this and do a better job of managing these women going forward.
It's like the GDM women, to follow them up and keep them under surveillance long term is a difficult task. Same thing with PCOS. Once babies are born and once it's out of sight, out of mind.
Yeah.
So yeah, must find a way to keep them in the under surveillance all the time.
So I think that concludes this session because we have kind of run out of time. So thank you to all the three professors for making this discussion really great. I think it's over to Dr. Tejal now for the takeaway points. Dr. Tejal?
So hi everyone, can I quickly share my screen? I think there's a question left, or should we go on? Okay. So is my screen visible to everyone?
Yeah.
Yeah. So I quickly coined the term prolactin pearls, but then I realized it's more than prolactin that we're talking about. But so I'll just quickly go through some of the key messages with Professor Molitch addressed in his talk, and also some of the key messages from some of the cases that we've discussed. I'm not addressing each and every one of them. Just in the physiology to highlight what is the reason for hypogonadism and hyperprolactinemia. That now the decrease in kisspeptin and thus the GnRH and then the FSH-LH is responsible for the hypogonadism. But not to forget, there's also some peripheral action, and there's reduction in aromatase activity as well as reduction in 5-alpha reductase activity in women and men respectively. I love this. Don't test unless there are symptoms. I think we do investigations all too often ordering an investigation and then not knowing what to do with it. So this is very important, that don't test unless there are clear-cut symptoms. All tumors more than 3 centimeter, pituitary tumors, we need to do prolactin in dilution 1:100 to rule out the hook effect if the prolactin is normal or only slightly elevated. So most tumors more than 3 centimeters, we need to keep this in mind. Some other points that he brought up during the treatment was that the normalization rates after surgery, even with expert surgeons, are not that great, especially for macroadenomas, which range from about 10 to 40%. And what I'm trying to say here is that whenever we have a patient who has a prolactin secreting macroadenoma, we need to realize that we are with this patient for the long haul, and we need to be patient and explain everything accordingly, and everything needs to proceed in a stepwise manner. Even with microadenomas, the cure rate is not 80%, the normalization, not 100%, the normalization rates are still 50 to 80%. What he also brought up is that 15 to 20% of patients do not respond to conventional doses of cabergoline. And in patients who are using a dose which is more than 2 mg per week, we need to do a baseline echocardiography. And depending what you find in that baseline echocardiography, you plan how frequently you're going to do a follow-up. Impulse control disorders which are emerging, and the series from Turkey, which you highlighted of about 300 patients, which showed pathological gambling, hypersexuality, and a couple of other things. So those are things we need to keep in mind and maybe do a proactive history taking. In patients with very large prolactinomas, if there is CSF rhinorrhea, then beta-2 transferrin is a good test to do because it's specific for the CSF and is not found in the nasal mucus. Some of the key takeaways from the cases that were presented, and Dr. Jayashree asked that what is the size of the microadenoma beyond which you would check for hypopituitarism, and that is more than 6 millimeters. And what Dr. Molitch emphasizes, it's usually GH is the one which is most likely to be deficient at this stage of the prolactin of the adenoma size. And then of course a cortisol-free T4 and prolactin would be other tests we do. What I also liked is that he does not repeat the pituitary evaluation every year, but only if the size of the tumor is increasing, only then we need to repeat all the pituitary tests. So that's important, so we don't end up wasting the patient's money, and we're judicious with the investigations. Dr. Chitra's case about the isolated stalk thickening, what he emphasizes that IgG4 associated and the other differential diagnosis which we have, usually pituitary also will be involved. And a follow-up and evolution of the disease is probably a better option than doing a biopsy, which can in itself have problems for the patient and cause hypopituitarism. Also, that post-LYH, post-lymphocytic hypophysitis, hypopituitarism is not likely to resolve. And he said this a couple of times in his presentation. And when somebody asked him that, should we think of withdrawing the hormones, he seemed pretty much final about it, that mostly in LYH, the hypopituitarism is not going to resolve. About the subclinical hypothyroidism. So in the subclinical hypothyroidism, I'm so sorry. In the subclinical hypothyroidism, Dr. Usha brought up some a very important point. There are lots of reasons for mild elevation of TSH other than just the thyroid itself. So weight gain, heterophilic antibody interference, and the age of the patient, the symptoms of the patient, and the desire for fertility should decide treatment. I think most of us agree that if the TSH is less than 10 in a non-pregnant woman, we would not like to treat. And lipid elevation is not an indication for thyroid treatment, because as Dr. Usha said, though the LDL levels tend to fall, however, the long-term cardiovascular risk reduction is not really seen. The last one or two slides, growth hormone therapy in adult women with hypopituitarism. So what he remarked is that it is not proven to reduce mortality, doesn't have any benefit in improving fertility, and there's not really any very hard data for that. However, it will improve bone health, will improve the fat muscle mass and the quality of life. However, what he emphasizes that some patients seem to have a dramatic improvement in quality of life, and some patients don't seem to have and say, doctor, we don't feel any different. And what he also highlighted is that Sheehan syndrome, something like that, which is an acute loss of growth hormone, has much better response with the growth hormone therapy as compared to patients who have been having growth hormone deficiency for a very long time. They don't seem to have very great changes in their quality of life. In the case which Dr. Belinda presented of a young girl who's short at 11 years of age and prepubertal, of course, we have to think of Turner syndrome, small for gestational age and growth hormone deficiency, but also asking the parents whether they were short and had puberty late is an important pointer to maybe CDGP, and a falling growth centile rather than a girl who's always been below third centile, that should lead us to suspect an intracranial occupying lesion or some other pathology. In the PCOS, this was the last case which was discussed in an adult woman with PCOS. When we talk about CV risk factors, we need to look at all the CV risk factors and then decide whether we need any treatment or not. Specifically for statins, you need to look at everything. What I liked what Dr. Uma said very specifically is that we tell the women that they need to take care of their lifestyle, but a lot of time we don't give them any tools to actually achieve that. And there needs to be a system in place where women have access, and these young girls and women have access to a systematic plan to help them to follow their lifestyle rather than, just arbitrary, oh, take care of your lifestyle and everything will be fine. She also talked about how endometrial carcinoma is a real risk in these women, and having a higher degree of suspicion for women who've had oligomenorrhea, even if they're at a younger age, and erring towards maybe sampling more as compared to women who don't have oligomenorrhea. In them, your screening suspicion will not be that great. And I think that about sums up everything. Thank you so much, all the speakers and moderators.
That is absolutely great. So we now go to the Q&A with Aishwarya.
Good evening, everyone. So That was a very nice summary by Dr. Tejal. So I'll quickly go through some of the questions which I've tried to kind of summarize from both the panelists as well as some of the audience, the delegates in the audience. Right. So the first question would go to Professor Molitch. So this question, I'll give it in three parts. It's about the use of cabergoline for prolactinomas. So the first part of that question would be, what should be the intervals for titrating a dose of cabergoline once you've started it? So that's the first part of that, because we know that some of them do fall rapidly, but some take some time to drop. So what is the frequency with which we would titrate a dose? And what's the highest dose that personally you have used while treating a patient with prolactinoma? And when would you call a person a non-responder to cabergoline?
So I usually will increase the dose or check prolactin levels every 1 to 2 months and then increase the dose accordingly. The highest I've ever used is 3 milligrams per day, but that was really only in one patient, but I've often gone up to 1 or even 1.5 milligrams per day in some patients. So you can go up, but clearly those who are getting more than 2 milligrams per week, then I do echocardiograms yearly in those patients following them along. The higher the dose, the more concerned I am of valvular abnormalities, but I've really only seen that occur once in all of the patients that I've treated.
So thank you so much for that. The next question would be, what would be the role of temozolomide for a patient with a resistant prolactinoma? Like, would it be something that you could use to prevent a surgery in this patient, or would you use it prior to surgery? So this is a question from one of the other persons in the panel.
Temozolomide is an alkylating agent, and really sort of a last-ditch treatment rather than an early treatment. It has a lot of toxicity, and not everybody responds. So this is for patients who have continuing growth of a prolactinoma, or clearly have prolactin carcinoma or prolactinoma carcinoma that has distant metastases. So continued growth despite high-dose cabergoline, despite surgery, despite irradiation, and perhaps even somatostatin analogs. And then that's the kind of patient that I would consider using temozolomide. I would not use it just to prevent surgery.
Yes, thank you. So the next question would be, So the next question, there was recently a meta-analysis published in JCM about the role of surgery as a viable first-line alternative to treat prolactinomas. So what are your thoughts on that, sir?
I mean, I gave the data for surgery as first-line therapy where the microadenomas and macroadenomas. I think the data with dopamine agonists is better than with surgery and clearly has less adverse effects than surgery. I mean, surgery does carry mortality and certainly morbidity of hypopituitarism that can occur. So I'm not an advocate of doing surgery first. I think you can certainly talk about it with the patient as an alternative, but when I do that, very few patients prefer to have surgery first.
Professor Molitch, we also see patients who present to us with galactoria, but when you evaluate them, they do have normal prolactin levels. So what are all the things that you would consider this, and how would you, what are the factors you would consider, and how would you treat such a patient?
Well, patients occasionally, I mean, galactoria is not that uncommon even with normal prolactin levels. And, you know, most of the time you can reassure the patient. If it's very bothersome, if they have, you know, breast swelling and tenderness and a lot of galactoria, often you can treat that with a dopamine agonist to lower those normal prolactin levels down even to subnormal levels. And that will usually take care of the galactoria. And if you do that therapy for 2 or 3 months and then gradually reduce the dose and allow the prolactin levels to come back up, usually the galactoria doesn't come back. Very rarely do you need to continue the dopamine agonist in a patient like that.
So the next question I would like to direct to Dr. Uma. So there's a delegate from the audience who would want to know how do you manage menopausal symptoms and what is the role of non-pharmacological therapy for menopausal symptoms?
So, I mean, it depends on the nature of the menopausal symptom. What is it that the woman is having? Is it essentially vasomotor or is there disturbance of sleep? Is it vaginal dryness, dyspareunia? So a lot of they come to us with a variety of symptoms. Each one will need to be addressed in a slightly different fashion. I tend not to prescribe too many non-pharmacological methods, but other than modifications in their diet and lifestyle, which would generally be beneficial, I tend not to use plant-based estrogen, phytoestrogens, etc., because we really don't know what the impact is going to be. So usually if they have very severe, if they have very significant vasomotor symptoms that are debilitating, that don't allow them to go through a normal work day, and they're fairly close to their menopause, then we consider short-term HRT to tide them over. So the decision is based on the nature of the symptom, the severity, and how remote from menopause they come. I mean, we have women who come in sometimes saying they're having hot flushes or sweats, but they are 5 years from when their periods have stopped. In that situation, I'd like to know if there's any other reason for them to have flushes and vasomotor symptoms, because if they've not had it for the first 3-4 years after menopause and it suddenly started, we can't just assume that it is menopause related. We have to look for the other reasons also.
Thank you, ma'am. Dr. Usha, would you like to add something to that, ma'am?
Yeah, I agree with Uma. I also don't use any of the plant-based isoflavones or any of those things. Not only we don't know, we don't know also these are phytoestrogens. We don't know their effect on breast tissue and other tissues. So we just don't know. So I don't use those non-pharmacologic measures like that. One of the things that I may use is venlafaxine, but that's pharmacologic. It's non-hormonal. Non-hormonal pharmacologic venlafaxine in short term has helped lots of women. So that is something to consider. Again, like Uma said, it all depends on how disturbing. Many people just need reassurance. If you tell them that this is what happens to a lot of women around this time, it's transient. It's not, everything is not downhill from here. Things are going to get better, and all those kind of things, people do feel better. So maybe even things like physical exercise, yoga, meditation, all of those non-pharmacologic things definitely help. Wearing cool clothes, staying in cool rooms when you're, having those hot flushes. Those are, I think, simple advice you can give people, and venlafaxine.
Going back to Dr. Uma, ma'am, could you just tell us what are the things that you would actually look for when you said other reasons for hot flushes? So what are the things you usually think of? I mean, you're trying to rule out. Like, what would you do?
No, I mean, so I'm saying, obviously, if somebody presents with the typical hot flush and they are going through their perimenopause or they're immediately postmenopausal, we assume that it is because of the estrogen deficiency and we give them the advice. What I meant was we have had women who come fairly remote from menopause. Then you have to find out, is there hypertension? Is there uncontrolled diabetes? Is there other reasons for vasomotor symptoms? We can't, and that's not the woman that you would kickstart hormone replacement therapy, because you'll be doing more harm than good. So we would need to work up and find out if there's anything else that is giving her this flushed feeling or that needs to be addressed.
Thank you, Dr. Professor Molitch, would there be something you would want to add to this?
No, I would agree with what was said.
So I'll go to the next question. So what would be the ideal OCP that, this question I direct to both Dr. Usha and to Dr. Uma. So what would be the ideal OCP that you use in your practice when you're keeping in mind hyperandrogenism as well as the risk of DVT? So what are the usual combinations that you use in your practice? I'll address it first to Dr. Usha.
I think the present day oral contraceptives are a lot friendlier, and in terms of they are definitely less androgenic than before. And also they've come up with very nice low doses. So again, this is for treating hyperandrogenism, right, Aishwarya?
Yes, ma'am. Yeah.
So I usually tend to combine it with anti-androgen. So I don't use a big dose oral contraceptive. And then a background history of the patient. I think there is another clinical scenario we couldn't get through. This was a patient that who actually came to see me with who's 41 years old, and her menstruation stopped, and her FSH was high, except she has a history of some unexplained CVA that happened at the age of 26. Apparently, she was worked up fully, for hypercoagulable states and everything, and they never found a cause. So here is the kind of person you wouldn't touch with any kind of hormone therapy. So I'm just saying I would go back into the history of the patient, find out a lot about these kind of absolute contraindications that they may have, a family history of breast cancer and or estrogen dependent cancers, either the woman herself has had, or strong family history of coagulation problems. And then smokers and very obese women, I tend to stay away from oral contraceptives. So very quickly, I just want to say the hirsutism is very troublesome and embarrassing, but again, it's only a cosmetic issue. It doesn't do a thing to the health of the woman except psychologically. So if we can reassure a lot and use a lot of mechanical measures and maybe just some anti-androgens in these women who cannot take oral contraceptives. Otherwise, I use a low dose pill in combination with anti-androgen. Can ask Uma.
Uma, if you can.
Yeah, I think Usha's pretty much covered most of it. I don't think there's any clear advantage to using one type of pill over the other if we are just looking for cycle control. If there is hirsutism that the woman is complaining of, whether we want to use a drospirenone-based pill, which has a slightly, a progesterone which has more anti-androgenic activity, but most of them work just as well. And if they need an additional anti-androgen added on, then usually I do it in conjunction with an endocrinologist. But if we are just treating them for cycle control, then all of them work just as well. I tend to go with a 20 microgram estrogen pill. I'm not particularly, except in a specific situation where we want a slightly stronger anti-androgenic progesterone, they all work pretty much just the same.
Professor Molitch, is there anything you'd like to add to this?
Not really. Again, with the anti-androgen, when I do use that, I use a spironolactone in fairly high doses, but again, that almost always has to be combined with the oral contraceptive.
Yeah.
So the next question would be directed to Dr. Uma. So, ma'am, how long would you treat a patient with adolescent PCOS? How long would you wait for a lifestyle measure, weight reduction or something? How long would you wait for it to work? And as you know, many of adolescents are usually not very compliant with this. So, when do you, how do you deal with that? So, when do you take a call to start, and what do you what do you use?
Yeah. So. I think we have to keep motivating them for their lifestyle change. It is something that we need to work on, and if we are able to give them some focused guidance, many of them stick to it for a period of time, but they tend to relapse. It's important to handhold them or tell them to be careful when they go through periods of stress and change, typically if they're doing their board exams, typically if they're, you know, moving into hostel where their food, lifestyle, everything is likely to change. Those are periods when they need to be handheld and supported. So I mean, we give them a trial. I mean, I tend to give them ask them to do the lifestyle change, give them the rules for the exercise and give them a diet plan. Parallelly, at the start, I tend to use just progesterone for withdrawal. But sometimes they they forget, or they don't take the progesterone for after 60 days, or they bleed very heavily after they withdraw. Even if they withdraw after 60 days, then I tend to put them on the pill and ask them to do it for about 6 months and then come back. Personally, I don't start them on metformin as the first line because you don't know how long they're going to need it and what the other impact of it is going to be. But obviously, if they have other factors, if they're obese, if they have already some IGT or impaired fasting, then they will probably benefit. But there again, the lifestyle focus is probably going to stand them in better stead long term. So those adolescents, probably if they also hear the same both from their gynecologist and their endocrinologist, the motivation to stick to it is going to be slightly better. So those women, I think we need both groups to work on.
Ma'am, a quick question about there's one person from the audience who's asked about the role of milk and vegan foods as a lifestyle change for PCOS. Is there any, have you found any literature on it? Or
so I don't know is the right answer. I have read a little bit about about anti-inflammatory properties of milk, which is why you actually find a lot of people now choosing to go vegan. It's not something that I advise. We do ask them to carb restrict, and we ask them to change their plate portions. That's the basic advice that they give. If we need to do anything more, any of these crash diets or food fads are not going to be sustaining. So they will seesaw. So I think that is an important message to give them, and then put them on to a dietitian who will be able to monitor them more closely. Because if it's going to be anything more drastic in the diet, then it has to be supervised. It is almost like a prescription, isn't it? I can't just tell her to go off one category of food in the clinic and then walk away. That has to be more streamlined. I don't know if Usha or Dr. Molitch wants to say anything on that.
I agree with you, Uma. I think those fad diets and all that, the lycopene was fashionable in this milk business. The milk is so important. As ISBMR, I want to say that please everybody drink milk and have dairy. Otherwise, we won't get the calcium we need. Especially I'm just saying in Indian food, the greens and the dals and all that cannot make up for the amount of calcium that we need. So I don't prescribe any that kind of diet, especially to adolescents, because I think it has to be a healthy lifestyle trajectory they have to be put on for life. So there's no quick fix. What we have found with the young women with PCOS, young girls, is you find one thing that bothers them the most, and use that as the carrot. For example, if the acanthosis is bothering them a lot, or the acne is bothering them a lot, or some body image issue is, something about is bothering them a lot, then you just keep focusing on that. If you do this, you can stay healthy, plus you may be able to get rid of this, or some short-term goal. Talking to kids about you won't get type 2 diabetes or heart disease is not going to work. It all has to be, for them, short-term goals. Short-term gains, not goals. Yeah.
you, ma'am. Professor Molitch, would you like to add something to that? So
I agree with what's been said. I don't have anything to add.
So we are kind of out of time. So do we have time for one last question?
Yes.
So the question is again to Dr. Uma. She's, I think, the popular one today. So is menorrhagia a normal thing in the 40s? And what are the metabolic consequences of Mirena? This is the question from Dr. Chitra. Because there was also another question on IUCDs. So a little bit about the metabolic consequences of Mirena and whether menorrhagia is a normal thing in your 40s.
I don't think so. Change in cycle pattern can happen in your 40s. You know, the flow pattern can change. Your cycles can get slightly shortened or slightly delayed. But menorrhagia, as you know, as in excessive bleeding during your period, is not normal. So if you have that, it certainly needs to be evaluated. There could be an endometrial polyp. There could be adenomyosis. There could be other reasons for that are non-hormonal that could cause menorrhagia. So certainly it needs an evaluation and an ultrasound, including a good transvaginal ultrasound, to ensure that we are not missing any other endometrial pathologies such as polyps. And if there are no small submucous fibroids, no polyps, and there is menorrhagia, tranexamic acid is what we would normally try and we would offer Mirena. I mean, in the UK and in Europe, the hormone IUS is offered as first line. Here, we tend to do a trial of tranexamic acid before we offer the progesterone intrauterine system. I'm not aware of any metabolic consequences of insertion of a Mirena coil. The amount that is absorbed into the system is actually very, very small, because 30 micrograms of levonorgestrel is getting into the endometrial cavity, and an even smaller proportion of that is going into the system. So if we are happy to give medroxyprogesterone, 10 milligrams for 10 days in a cycle, that's much, much more progesterone than the Mirena IUS can actually, what gets absorbed. So I personally do offer the Mirena quite often. There are some women who have bloating, some weight gain. If you're acutely sensitive to even that dose of progesterone, there can be breast tenderness. They have described some thick cysts, ovarian cysts, but quite rare. What we need to counsel these women, however, is that they have to put up with some degree of spotting, intermittent spotting through the cycle for 3 to 4 months. And then the woman, usually it's interesting because they would be fed up of, pouring every month, but then they're equally intolerant of a little bit of spotting through the cycle. So unless they are counseled and prepared to handle that, you'll be putting it in and taking it out after a couple of months. So that degree of counseling has to happen.
Can I ask Professor Molitch a question? Because that was one of the patients we could not, get to today. So, Mark, when we have young women who have had either craniopharyngiomas or other pituitary tumors as young girls or adolescents, and now they are, and they've been operated, had radiation, and some may have a small remnant, some are completely, cured, and now they are ready for having a baby. So they want to know the feasibility and risk of the tumor coming back.
Well, I mean, if they're hypopituitary, obviously they're going to need ovulation induction of some sort. But assuming that they are able to get pregnant, there should not be any adverse consequence on any tumor remnant. On the other hand, if you still have a fair bit of pituitary tissue left, and the patient's not really very much hypopituitary, then you can get lactotroph hyperplasia during the pregnancy, and that might itself then elevate any tumor remnant to perhaps compress the optic chiasm. So that is a potential rare concern in some patients, but overall, I'm not terribly concerned about that. If it does occur, a lactotroph hyperplasia pushing the, for example, craniopharyngioma remnant up, then treatment with a dopamine agonist should take care of that very readily.
Great. Thank you so much. Thank you so much. I think we have come to the end of a really exciting session. If no one else has any questions for Professor Molitch or for Uma, I think we should call it an evening. And thank you all so much. And big thanks to Mark. Great to see you.
Nice to see you.
Yeah. And next slide, please. Just want to thank all the sponsors who have been so kind as to make sure that this information that Dr. Molitch is doing this program has reached many, many hundreds of doctors across India. Thank you so much. And tomorrow's program promises to be another winner because it's Dr. Mohan as the keynote speaker and Anjana and Archana talking about type 2 and type 1 diabetes. Really excited about that as well. Thank you all again and have a great night. And for Mark, a great day.
Thank you.
Thank you so much. Thank you all.
Thank you.
Thank you, Jayashree. Thank you, Belinda. Thank you,
Thank you.
Chitra.
Bye.
Thank you, everyone.
Thank you, everybody.